Hello, this is Eric Strong again from the Palo Alto VA and Stanford University. This is the 17th lecture on understanding ABGs, and the topic is the effects of supplemental oxygen. The learning objectives with this lecture are to be familiar with the various options for delivery of supplemental oxygen and how they determine FiO2, to be able to apply the alveolar gas equation to situations in which supplemental oxygen is being used, and finally to be aware of the effect that intrapulmonary shunting has on the determination of the AA gradient. In the last lecture, we reviewed the alveolar gas equation, and we also simplified it as such for situations where patients were breathing room air and at sea level. Unfortunately, this is frequently not the case, as many patients receive ABGs while on supplemental oxygen. So how does this impact assessment of the AA gradient? To answer that question, we need to first review the options for oxygen delivery, and there are many. Here is a chart outlining a number of options and the approximate maximum values of the delivered FiO2 that I have compiled from numerous sources. Some of these values may be different than you've heard before. For example, it's frequently cited that nasal cannula can only provide 40% FiO2, or you may be wondering why non-rebreather masks and mechanical ventilation don't provide 100% FiO2. We'll talk about these discrepancies over the next couple of minutes. Before going over each option for oxygen delivery, I want to review the frequently misunderstood terms of high flow and low flow oxygen delivery systems, because it doesn't mean exactly what you probably would guess. A high flow system is one that meets the patient's full inspiratory flow requirement and one in which the FiO2 is independent of the respiratory rate. Essentially, the only true examples of this are the Venturi Mask and positive pressure ventilation, such as a mechanical ventilator. A low flow system does not necessarily meet the full inspiratory flow requirement, and thus FiO2 varies depending upon the respiratory rate. Examples of this are essentially everything else. Why this distinction is confusing is that a non-rebreather face mask with 15 liters per minute of inflow, and which can provide as much as 90% FiO2, is a low flow system, while a Venturi mask set at an FiO2 of 28% is a high flow system. The primary reason these categories are important is that only high flow systems allow one to know the precise FiO2, and therefore calculations of the AA gradient of anyone on a low flow system will necessarily be only an estimate. So here is a picture of the most common means of delivering oxygen, the nasal cannula. It's nothing more than a plastic tube that wraps around the head, usually over the ears, and delivers pure oxygen through two prongs in the nose. It's not an airtight seal, however, so when the patient inspires, room air flows into the nose from around the prongs. The amount of oxygen delivered in this way can range from 1 to 6 liters per minute, provided either by a portable oxygen tank or through a port built into the wall of almost all hospital rooms. Flow rates equal to or greater than 4 liters per minute should be humidified to prevent excessive drying out of the nasal mucosa. Although more flow than 6 liters per minute can be physically delivered through the tubing, studies have failed to demonstrate any benefit in terms of greater intra-arterial oxygen levels. Therefore, if a patient's O2 sat dictates more oxygen than 6 liters per minute, the patient should be switched to a different delivery system. The precise amount of oxygen that is delivered to a particular patient via nasal cannula is impractical to measure at the bedside. However, there are a few general rules or principles. The first is that the faster the respiratory rate is, the lower the FiO2 is at any level of oxygen flow greater than just being on room air. So what exactly does this look like? Here is a graph of FiO2 as a function of respiratory rate. Here is room air, which provides exactly 21% oxygen at any respiratory rate. Here is 2 liters per minute, and 4 liters per minute, and 6 liters per minute. At a normal respiratory rate of 14, we can see that there is significant discrimination between FiO2 depending upon flow rate, and the FiO2 with 6 liters is somewhere between 45 and 50%. However, for a variety of reasons, most hospitalized patients don't have normal respiratory rates. For example, on 6 liters, the FiO2 sharply declines between 14 and 20 breaths per minute, and then almost levels off at just under 40%, which explains why 40% is frequently cited as the maximal FiO2 for nasal cannula. Also note that at extremely high respiratory rates, such as 40 breaths per minute, not only is the FiO2 at each flow rate much lower, but each additional liter provides little incremental benefit. Therefore, hypoxic patients who are very tachypnic should generally not be started on nasal cannula and instead be given oxygen through a mask. Although I've mentioned that there is no definitive way to determine FiO2 for a patient on nasal cannula, there are a few equations used to estimate this. Here is one such equation where estimated FiO2 is equal to 21%, or 0.21 plus 0.05 times the flow rate in liters per minute. Unfortunately, this is only accurate at normal respiratory rates. Here is a better estimate of FiO2 for hypoxic patients in the hospital who are generally tachypnic. The flow rate here is multiplied by 0.03 instead, but this is still just an approximation, and whenever possible, ABG should always be measured while the patient is either on room air or at the very least with a Venturi mask. Before I move on to some face masks, I want to dispel two related and pervasive myths about nasal cannula. First, nasal cannula is less effective in patients who predominantly breathe through their mouth. Second, that it is occasionally appropriate to put nasal cannula in the mouth for mouth breathers or for patients with nasal congestion. These are both false. In fact, there's actually some evidence that mouth breathers counterintuitively achieve higher FiO2s than nose breathers. For an explanation of how this could be the case, I suggest talking to an experienced respiratory therapist, as these myths are pet peeves for many of them. So now, let's discuss face masks. Among low-flow systems, there are three common options. First is the simple face mask, shown here, which consists of a single lumen tube connected to the bottom of the mask. There are no valves and no reservoirs other than the mask itself. Next is something called the partial rebreather. With this mask, there is a reservoir attached to the bottom of the mask. With each breath, the patient will first draw in some previously expired air that may be still sitting around inside the mask, but will then draw in a big bolus of 100% oxygen stored in the reservoir with a smaller additional contribution of ambient room air that sneaks in through the expiration holes in the mask. The partial rebreather mask has a single one-way valve here, which prevents expired air from entering the reservoir, ensuring that it is 100% oxygen. Last, there is the non-rebreather mask. This looks very similar to the partial rebreather, and there is the same one-way valve attached to the reservoir here. The difference is that there are also one-way valves over the expiration ports of the mask. Therefore, if the inflow rate of the oxygen from the tubing is high enough, it will flush out the carbon dioxide-rich air from the inside of the mask after expiration, and with one-way valves over the expiration ports, room air cannot enter the mask during inspiration. Because not all the carbon dioxide gas actually does get flushed out of the mask, and because some will be retained in the pharynx and trachea, it isn't possible to achieve true 100% FiO2, but most estimates of maximum FiO2 are in the 80 to 90% range. There are a few important practical rules to using face masks. The first is that oxygen flow must be at least 6 liters per minute to prevent the buildup of carbon dioxide in the mask. Having lower flow rates through the mask can theoretically cause hypercapnia. Next, at no point during the respiratory cycle should the reservoir be completely deflated, and this is implying the patient's minute ventilation is significantly outstripping the flow of oxygen and may contribute to the sensation of dyspnea. If this happens, the simple correction is to turn up the oxygen flow rate. Finally, due to the one-way valves on a non-rebreather face mask, if the inflow tube becomes kinked or otherwise obstructed, the patient will rapidly asphyxiate. Because of this, many hospitals have policies in place that require one of the one-way valves to be removed at all times. Here is a picture of an air entrainment mask, more commonly referred to as a Venturi mask. This is after Giovanni Venturi, an Italian physicist who first described the Venturi effect, which is nearly universally, yet probably incorrectly, attributed as the mechanism by which the mask is able to work. The notable distinction about the Venturi mask is that it is able to deliver a fixed amount of FiO2 at specific values up to and including 50%. With this particular model, each colored nozzle represents a different FiO2. Here are two additional models of Venturi masks. The one on the left is the only type that is available at my own hospital, and the one on the right is known by its trademark name Venturi Mask, which is occasionally used to describe any Venturi mask. Let me describe exactly how this mask works because I think it's pretty interesting. I'll use a cartoon representation of the specific brand of mask at my hospital, but the general principle applies to the other masks as well. This gray pentagon will represent the actual face mask with the outflow ports here, and a green air regulating attachment is underneath. Here's the elastic band that wraps around the head to hold it in place. You may need to use a little imagination for this. On the regulator is a hole whose size varies depending upon what FiO2 the middle section is dialed to, in this case 28%. Then a tube connects the regulator to the wall outlet from which flows 100% oxygen. As air flows through the inflow tube into the regulator and past the open hole to the mask, room air is drawn into the hole by the process of entrainment. The hole is made the exact size necessary for the ratio of oxygen to entrained room air to result in a specific FiO2. The beauty of this process is that once the flow rate of oxygen from the wall outlet surpasses a certain threshold, any additional oxygen flow that is added only serves to proportionally increase the entrainment of outside air, such that the ratio remains constant. In other words, with this example, whether the wall outlet is set up to 5 liters, 10 liters, or 15 liters, the FiO2 will be a rock-steady 28%. Since no one can ever remember the minimum flow rate for a given FiO2 for Venturi masks, the standard practice is to always set it up to 15 liters. However, if trying to save the hospital money or resources, you could always look up the appropriate values in the chart that comes with the mask. Now what happens if we want to increase the FiO2, let's say to 35%? This middle section turns like so, and now with a dial at 35, the hole becomes smaller. Thus, less room air gets entrained, and the ratio of oxygen to room air increases to provide the higher FiO2. Here are two less common oxygen delivery systems. The first is the open face tent, occasionally used for tachypnic patients requiring relatively high FiO2, but who feel claustrophobic or otherwise uncomfortable with a standard face mask. And here are two similar devices with the oxygen mustache on the left, which is more commonly known by the trademark name oximizer. On the right is the oxygen pendant. These two devices are more or less hybrids of nasal cannula and a face mask, in that they are worn like nasal cannula, but have an oxygen reservoir from which they draw air. I don't know of any head-to-head comparisons, but I suspect the oximizer to be the more effective of the two. So now that we've seen the options for oxygen delivery, how do we actually go about calculating the AA gradient for a patient on supplemental oxygen? I think this will be very clear after going through two quick examples. To remind us, here is the alveolar gas equation. First, we have a patient on 50% FiO2 via Venturi mask who has this ABG with a pH of 7.48, PCO2 of 32, and PAO2 of 120. Plugging these numbers into the above equation, we find that we have an alveolar oxygen tension of 317 millimeters of mercury. The AA gradient is the difference between the calculated alveolar oxygen tension and the directly measured arterial oxygen tension, so 317 minus 120, or 197 millimeters of mercury, a fairly high value. For the second example, we have a patient on 2 liters via nasal cannula with a pH of 7.33, PCO2 of 46, and PAO2 of 92. Before we can calculate Pbig-AO2, we must determine FiO2. Remembering from earlier in the lecture, the FiO2 of a patient on nasal cannula can be very roughly estimated as 0.21 plus the product of 0.03 and the oxygen flow in liters per minute. In this case, this is 0.21 plus 0.06 or 0.27. Then we plug this into the alveolar gas equation and get 135 millimeters of mercury. So the AA gradient for this patient was 135 minus 92, or a closer to normal 43. A comparison of these two examples illustrates that for a patient on oxygen, one cannot make an assessment of the adequacy of a patient's gas exchange solely from the P(a)O2. As in the second example, P(a)O2 of 92 is obviously lower than that from the first example, yet the first patient clearly has a more serious gas exchange abnormality. The next topic to discuss is how supplemental oxygen affects shunting. For those of you not familiar with this term, a shunt is a situation where blood bypasses the anatomic pathway it typically travels. There are several different types of shunt, which have different anatomic locations, bypass structures, and direct effects on arterial oxygenation. Right to left shunts have two subtypes. First are intrapulmonary shunts, which bypass the alveolar capillary membrane and therefore don't participate in gas exchange. This can be a macroscopic shunt, for example, a large pulmonary arterial venous malformation, or AVM. Alternatively, and much more commonly, this can be a diffuse and or microscopic shunt, such as occurs when alveoli get flooded by pulmonary edema or pneumonia. The second subtype of right-to-left shunting is intracardiac, in which the lungs are bypassed entirely by some portion of blood flow. In all right-to-left shunts, oxygen-depleted blood makes its way from the right side of the heart to the left side of the heart without undergoing gas exchange. Therefore, these shunts have a significant direct effect on oxygenation. In contrast to this, left-to-right shunts, such as a ventricular septal defect, can only occur in the heart, where the bypass structure is the entire systemic circulation. Because there is no deoxygenated blood being introduced into the systemic circulation, there is minimal effect on arterial oxygenation. The effect is not necessarily zero, however. If the left to right shunt is large enough fraction of the total cardiac output, the increased blood flow through the pulmonary vasculature can force blood through segments that are usually relatively vasoconstricted due to local hypoxia from a regional low ventilation, a process that falls under the umbrella of VQ mismatch. Both shunting and VQ mismatch will be discussed much more in Lecture 18. For now, this is the type of shunt that we are interested in, an intrapulmonary shunt that can be picked up by analysis of the ABG. From the perspective of how to analyze ABGs from patients on supplemental oxygen, there is another way in which intrapulmonary shunting can be categorized. First is physiologic shunting that is caused by the supplemental oxygen itself. The mechanism of this phenomenon, which is seen in empiric data, is not well understood, but is thought to possibly involve dysregulation of hypoxic vasoconstriction. A common way to include this effect is to adjust the normal AA gradient for the amount of FiO2 the patient is receiving. This can be done with this equation, which again is based on empirical data. The first component, the age divided by 4 plus 4, is simply the equation for the normal AA gradient on room air. And the second component, 50 times the difference between FiO2 and 0.21, is the adjustment for the physiologic shunt. It would probably make more sense to utilize P big AO2 instead of FiO2 for this adjustment term, which would therefore be relevant at high altitude. However, the empirical data from which this equation is derived was done at sea level and with reported FiO2, so that's what we're stuck with for now. The second cause of intrapulmonary shunting is pathologic shunting, which is unmasked by supplemental oxygen. An AA gradient that increases as FiO2 increases, but out of proportion to induced physiologic shunting, as calculated above, must be the consequence of pathologic shunting. At this point, I'm going to go through 3 examples of how supplemental oxygen impacts the analysis of an ABG. Example 1. An 80-year-old man with COPD presents to the ER with progressive dyspnea and cough for 3 days. He appears acutely uncomfortable and is sitting up leaning forward with his hands on his knees. His temperature is 98.5, heart rate 104, blood pressure 135/80, respiratory rate 30, and O2 saturation 95% on a Venturi mask set at 30%. Here is his ABG: pH 7.28, P little a CO2 80, and P little a O2 80. Step number 1 is to check the AA gradient. Here's the alveolar gas equation to calculate the P big A O2. We plug in our numbers from this example and we get a P big A O2 of 114 millimeters of mercury. As the AA gradient is P big A O2 minus P little a O2, this will be 114 minus 80, or 34. The next step is to estimate the adjusted normal AA gradient. Here's our equation for estimating the normal AA gradient of a patient on supplemental oxygen. Plug in our numbers and we get 29. 29 and 34 are close enough to say that this patient has a normal AA gradient. Therefore, the etiology of his hypoxemia must be solely his hypoventilation. With that additional information, combined with a very brief clinical vignette, the most likely diagnosis is probably a COPD exacerbation. Example number 2. A 64-year-old man with a history of coronary artery disease presents to the emergency room with a sudden onset of dyspnea 1 hour ago. He is in moderate respiratory distress with rapid shallow breaths. Current vitals are temperature 97.2, heart rate 115, blood pressure 95/40, respiratory rate 30, and an oxygen saturation of 100% on 6 liters via nasal cannula. His ABG on 6 liters shows a pH of 7.54, P little a CO2 of 28, and P little a O2 of 143. Let's analyze his oxygenation. Step 1 is to check the AA gradient. To do this, we need to estimate his FiO2. If you recall, for a typical patient, a reasonable estimate can be made by taking 0.21 and adding 0.03 for each liter of oxygen. This patient, that gives us an FiO2 of 0.39. We plug this and the P little a CO2 into our alveolar gas equation and find a P big A O2 of 243 millimeters of mercury. Thus, the AA gradient is 243 minus 143, or 100. Step 2 is to estimate the adjusted normal AA gradient. As we saw before, here is our equation for that. Plug in our numbers and we get a normal AA gradient at this FiO2 of about 29 millimeters of mercury. Since 100 is much greater than 29, this patient can be said to have an elevated AA gradient hypoxemia. What's the most likely diagnosis? The clinical scenario describes a very abrupt change in respiratory status. The most common causes of an abrupt elevation in the AA gradient are pulmonary embolism, a large acute myocardial infarction, a pneumothorax, mucus plugging, fast tachyarrhythmia, or hypertensive emergency. The vitals rule out the arrhythmia and the hypertensive emergency, and we aren't told about any chronic lung condition that would make a pneumothorax or a mucus plug particularly likely. This leaves either PE or acute coronary syndrome with secondary pulmonary edema, either of which could result in this patient's tachycardia and mild hypotension, in addition to the abnormal gas exchange. And last, here is example 3. A 44-year-old man with a history of intravenous drug use is brought to the ER by friends after he was found confused, wandering outside his house. He is currently complaining of shortness of breath and feeling, quote, real bad. On exam, he appears acutely ill and is in severe respiratory distress. Temperature is 102.5, heart rate 125, blood pressure 84/45, respiratory rate 44, and O2 sat 75% on room air. He has diffuse bilateral crackles, a 3 out of 6 systolic murmur throughout the precordium, and a flat jugular venous pulse. His room air ABG reveals a pH of 7.39, P little a CO2 of 26, and P little a O2 of 48. We will ignore his interesting acid-base arrangement and start with checking his AA gradient. Since he's breathing room air and is presumably at or near sea level, since we're not told otherwise, The alveolar gas equation reduces to this: 150 minus the p little a CO2, which is 26, divided by 0.8. The result is 118 millimeters of mercury. The AA gradient is therefore 70. Step 2 is to estimate a normal AA gradient for a patient of this age, which would be 44 divided by 4 plus 4, or 15. Therefore, we have a mild to moderate elevation of the AA gradient. Now suppose the patient is put on 15 liters of oxygen via a non-rebreather mask, and the ABG is repeated to reveal this. How do things change? Step 1, check the AA gradient. Since estimates of maximum FiO2 via non-rebreather range from 0.8 to 0.9, let's just take the average and say about 0.85, and plug this into the alveolar gas equation. Although this may seem a little arbitrary, these equations provide only estimates anyway. We get a P big A O2 of 572 millimeters of mercury. The gradient is therefore 572 minus 230, or 342. Now let's estimate the adjusted normal AA gradient if we plug in the patient's age and the estimated FiO2 of 0.85. We arrive at 47 millimeters of mercury. So what happened? A gradient that was 55 millimeters of mercury above normal while on room air increased to about 300 millimeters of mercury above normal when on a non-rebreather mask. The only possibility is that some degree of right to left shunting is occurring. While it's possible from the ABGs alone that this right to left shunt could be intercardiac, the clinical scenario strongly suggests the shunt is intrapulmonary. This amount of shunting in a patient who appears to be in septic shock is usually due to one of two possibilities. First, he may have a severe pneumonia, or second, and not by no means mutually exclusive, he may have developed a condition along the spectrum between acute lung injury and ARDS, technically the former in this case based on the fact that his PaO2 to FiO2 ratio is about 270. Any cause of sepsis can trigger acute lung injury, but in an IV drug user with a loud heart murmur, endocarditis better be near the top of that list. Therefore, for this patient, the most likely diagnosis is severe sepsis and acute lung injury, secondary to either pneumonia and or endocarditis. So that's it for how supplemental oxygen affects assessment of the ABG. You may have noticed that during this lecture I've used the words approximately and estimated both numerous times. This highlights the fact that despite the exact sounding equations and the protocolized approach, analysis of oxygenation should not be too dogmatic, just as it should not be too dogmatic with analysis of acid-base status. The next lecture will cover the specific etiologies of hypoxemia and will include further discussion of shunting and VQ mismatch.